I have the pleasure to invite our guest, Dr. Christian Morgenstern. Dr. Morgenstern is a world-class leader in endoscopic spine surgery from the Morgenstern Institute of Spine in Barcelona, which pioneered endoscopic spine surgery in Spain for more than 20 years. Dr. Morgenstern has been an invited speaker and faculty in international spine surgery meetings at the highest level. Is an invited faculty for international workshops of endoscopic spine surgery and will host us a lecture today on opioid-free and awake percutaneous and endoscopic TLIF surgery with a large footprint interbody cage. Welcome, Dr. Morgenstern. It's a pleasure to have you today.
Thank you very much for having me. Can you hear me well?
Yeah, we can hear you.
Great. Okay, so I'll start right away.
Yeah.
Okay, so thank you very much for the kind invitation again to Dr. Choi, Dr. Gun Choi, and well, excuse my voice. It's unusually cold in Barcelona this time, so I have a bit of a cold. Yet not so cold as in Pohang, yeah, but still for us it's cold. Well, I'm going to start talking about endoscopic TLIF surgery and how we have been developing the technique in the last 15 years so that it becomes an awake surgery, no need for general anesthesia. And right now we're using large footprint interbody cages, and I'll talk you through my technique. So these are my disclosures, so don't believe a word I say. And well, as you all know, controlling pain is very important during surgery and after surgery. It's one of the most important aspects to get the patient well after having surgery. And you all have heard about the opioid epidemic in the US. So there have been a lot of overdose deaths. Can you see my slides moving?
Yes, we can see your slides moving. Yeah, smoothly.
Oh, okay, great. Thank you. Well, so despite all the opioid deaths, the spine surgeons have had the longest prescription duration of all surgeons, ranging up to 13 days, which is a lot for a surgery. So 2 weeks of opioid medication after surgery, which basically results in many people getting hooked to opioids. And so there's a lot of people in the US blaming physicians for at least part of the opioid epidemic. And so we have been looking for strategies also in Europe to reduce opioid consumption. You all know the adverse effects of opioid pain medication. So basically, I work with two different pain control strategies. One is on the side of surgery, which is where I will incide right now. And the other one is with anesthesia and analgesia, which will be the second part of my talk. So regarding the first part, the type of surgery you all know, minimal invasive spine surgery, and the rationale behind it. We want to decrease blood loss. We want to decrease postoperative pain. And especially what we want to do is we want to put patients on their feet as quickly as possible, because there are many studies showing that as soon as a patient starts moving, then the rate of complications decrease. So this is where we want to go. And so in Asia, especially, endoscopic and percutaneous TLIF surgery has been quite popular in the last years. The basics are that we use cam and strangle through the neuroforamen to place a cage in. It prevents the resection of the facets like you would do in open TLIF surgery or with a tube in MIS TLIF surgery. And so you can just put a TLIF cage just like you would in open surgery. We bypass safely the exiting nerve root, and you can place an expandable cage if you want to increase the footprint of your cage. So this is basically, as you can see here, this is basically how it works. And of course, as a result, you have fast patient recovery, early hospital discharge, and you can do it without general anesthesia. We have been doing this for many, many years. So my father published his first case with endoscopic TLIF surgery back in 2010, as you can see here in this publication. So it's been a long, long time we started with this. We use different kind of expandable devices like this between spacer that you can see here, which this one we published in 2011 with Dr. Sang-Ho Lee, also from Korea. So we've been doing this for quite a long time. This is basically how it looks like. You can see here the expandable cage is placed, the percutaneous screws, and you can see the small skin incision on the side to place the cage. And you can see here very nicely how we also use the indirect decompression of the foramina and also sometimes of the central canal by using an expandable cage. So I think it's a very nice technique if you know how to indicate it well. Also for revision surgery cases, it can be very interesting because we bypass the posterior scar tissue that has been created by previous surgeries, especially if they had open surgery. Everything is glued together. You don't see the planes. So by using another approach, like you would with anterior or lateral approaches, you can use a posterolateral approach in percutaneous surgery. And so you can bypass the scar tissue and reduce the risks of surgery. Like, for example, in this case, 62 years old male who came to us from Argentina, he had a TLIF surgery, like posterior lumbar interbody fusion, and they only placed one cage on one side. I don't know why. So for TLIF, usually you place two cages, and you could see that he came to us with this foraminal stenosis on the contralateral side. And so when we did a CT scan, we saw that the percutaneous screws, everything was okay. So he had no arthrosis, no osteolysis, no loosening of the screws. So instead of removing all the hardware and redoing the fusion, we just placed in a cage from the other side. And then the patient was doing well and the radicular pain was gone. So this is just to give you an idea of how we use this technique to think outside of the box. And then we try to find new ways of helping people. We have published a lot on these techniques in the last 10 years. So you can see here our publications. And the problem that we see with endoscopic TLIF surgery nowadays, so right now in the present, is despite it has been seen an exponential growth, especially in Asia, it's still limited mostly to endoscopic spine surgeons. So you need to know endoscopic spine surgery, you need to have the equipment, you have to have learned the technique, and you also need specific expandable cages, which are usually more expensive than regular standard TLIF cages, and they usually have a small footprint. So all the risks that are enclosed to that. And of course, the temporary desesthesia, we will get to that later. So what we wanted to do is we wanted to develop this technique and try to increase the adoption also by non-endoscopic surgeons. We wanted to create a universal delivery device that allows us to avoid using an endoscope, that we can use any kind of TLIF cage, also large footprint in the body cages. And we want, of course, to decrease the desesthesia rate. So this is what I'm doing right now. So I'm placing, as you can see in the lower level here at L5S1, a big TLIF cage. And I on purpose chose this case where I also placed some lateral cages on the upper levels, as you can see here. And you can see this cage, which I just marked in the red dot circle. So it's a big, huge TLIF cage. It's an expandable cage, and it has 39 times 12 times 14 millimeters of height. So it is a very big cage, and compared here in the screen to the lateral cage, you can see that it's almost as big as a lateral cage, which is really impressive for a TLIF cage. And in comparison to a specific cage that was designed for endoscopic surgery, you can see here the differences in size. So it's a very important increase in size and diagonal of the cage. So this is what we're using right now for endoscopic TLIF. Okay, so this cage has the advantage, of course, that I can have a great lordosis, up to 15 degrees of lordosis. I have a large end plate contact surface. And the design of the cage is special so that it can smoothly go through the foramen. As by being big, it also increases the stability. We have a huge area, as you can see in the middle of the cage. You have a huge area for a bone graft substitute and placement, and you can expand it to up to 50 millimeters, which is quite an important height. Of course, a big cage through a small hole, as you will imagine, poses big challenges. It requires a wide foraminoplasty. You have to be very careful with the nerve root unless you don't want to have postoperative dysesthesia. You have no margin of error in the trajectory and the entry point of the cage. If you miss that, you won't be able to put in such a big cage into a small disc. And it has a strong mechanism of expansion, so be careful with the end plates. So all in all, placing a big cage endoscopically through cambium strianal is quite challenging. This is the technique I use. So I developed with the company from Jaap Hoekland, Maximore Spine. I developed a special dilator for to facilitate the bone, the fusion and the placement of a big cage. As you can see here, we're using a K-wire to find the way to the disc. And with the dilator, we go. I just go slipped into the neuroforamen, as you can see here. Once the dilator is placed into the disc, I remove the dilator, and I have I call it a shield or a sleeve, if you want, but it's half a sleeve actually, placed into the disc. And this is my highway to the disc. This way, I can just access the disc, as you can see here in the X-rays. So it's not as I'm not limited by the constraints of a full circled sleeve. It's just half a sleeve. So I have all kind of liberties with that. Then I use Jaap's Maximore manual reamers to do the foraminoplasty, and my sleeve is protecting the exiting nerve root. So I am no fear of actually damaging the exiting nerve root. So as you can see here, okay. So I think this is a very nice way of just protecting the nerve root without putting pressure on it. And I'm using manual reamers up to 12 millimeters of diameter. So it's big reamers, as you can see here. And this way I can just ream out smoothly the facet joint, the SAP, and then I have a big hole. Of course, if you want to be sure that you have enough space, you can alternatively use the endoscope if you know how to use it, and use the high-speed burr under endoscopic visualization, as I did here, and then you can do an even bigger hole. So you can see here how I took off the whole SAP with a high-speed burr. So depending on your choice of technique and on your skills, you can do either one. And you can see here, so endoscopically, I did a big and wide foraminoplasty just to be sure that I have enough space. When I do the disc preparation, I use regular TLIF tools. I don't need special endoscopic tools because I have a lot of space with my sleeve. So this here is just a regular curette that just came in with a regular standard TLIF cage. And this is a forceps. It's a big forceps that it also came with the instrument set of an open TLIF cage. So no need for endoscopic instruments, no need for expensive instruments. And this is the kind of discectomy that I get when I do the discectomy with this fusion dilator, which is quite okay. In comparison, I also do a lot of OLIF, as you have seen in my X-rays. So a lot of anterior to psoas approaches, and this is what I get usually with an anterior to psoas approach. Sometimes a little bit less, sometimes a little bit more. But with the TLIF, with this endoscopic TLIF instruments, you can do a nice disc preparation. And this is the big cage that I was showing you before. And I just slide it over this fusion dilator. As you can see here, you can see how much bone graft I just packed into the cage. And then I just placed it through the dilator, and I can control it with the X-rays. Of course, as you can see here, I don't have an anatomic reference. I do everything with the X-rays. It's purely percutaneous how I place the cage. So just by X-rays. And you can see here how I put in the cage. This is what I actually see when I have it in my hands. So I just have skin in front of me and the X-rays. And then I finally can expand it from outside by using the handle. So this is the final view of an expanded cage. So this is my technique, which we have been developing for the last years. And I think it's very interesting because you can use it on complicated patient like this lady, 72 years old, high BMI, many comorbidities. She went to many surgeons with back pain. Nobody wanted to touch her because of all the surgical related risks. And so she had difficulty walking. She needed the help of a cane. And let me show you with this video how I do the surgery. In this case, I did it with endoscopic burrs. So you just get the idea. So you can see here the degenerative scoliosis, degenerative disc disease in the lumbar spine with the vacuum sign in the discs. You can see the transforaminal approach with the endoscope, and I'm using a high-speed burr. This is what I actually see when I use the endoscope. And this is the SIP. You can see the bone. And with the high-speed burr, I just start drilling the neuroforamen. So it's basically, if you have done foraminoplasties, this is just a very similar way of doing it. And I just go checking with the X-rays and with a direct visualization up to the tip of the SAP. You can see here the facet joint moving on the left. So I can see I'm right now at the tip of the SAP. I know I have reached the whole SAP, and then I use the Kerrison punches to start decompressing until I can see the exiting nerve root. So I keep burring, I keep using the punches, and you will see now, so below here, you can see the exiting nerve root. There it is, pulsating. So I know it is free. And this is a very nice case, actually, because this lumbar exiting root had a double innervation. So you can see the two, you can see how two collaterals are coming. Here you see it, like a Y coming into the nerve root. So you can see the nerve root here, that it's exposed. I know I have done a big foraminoplasty. So now it's safe to actually place the cage using that dilator, of course. So I still use the shield. This is a postoperative CT scan, so you can see I did a big foraminoplasty with the burr. And this is the big cage I placed through that foramen using the fusion dilator I showed you before, just to ensure that the exiting nerve root is not harmed. 2 centimeter skin incision to place a big cage. This is the final construct that I did on her because, well, she needed not only a TLIF, but several fusions. And you can see here now the patient walking just next morning after surgery. And remember, she's a very sick patient. She barely could walk before surgery. And this is her the next morning, almost without pain. So I think it's a very interesting technique. And so this is the foraminoplasty. This is just another patient, 70 years old male. He had been operated 3 times previously before he came to me with this radiated red leg pain. And you can see here, this is a control X-ray that he brought to me. You can see he has an undersized cage at L3, L4. And this is just the X-ray when he came to me. And you can see the migration of the lumbar cage, and it's right into the neuroforamen. So this is what I did with him. I used the endoscope. Let me skip so this is the endoscope, and this is the view of the cage using an endoscope. So I was using an endoscope through the neuroforamen, transforaminal approach to just present the cage. You can see how the cage is moving. So the cage is completely loose, but I still have to get it out. And usually, if you do it with open surgery, this can be, well, it can be risky because you have the scar tissue of the previous surgery. It can be adhered to neural tissues. So I chose to use the transforaminal approach. I'm using here the cage handle to screw into the cage. It is a regular cage handle for an open TLIF cage. It just happened to fit through the endoscope. I took the biggest endoscope that I have, and I placed the handle through the working channel. And so I just keep trying. And here, finally, I'm able to secure the cage and under endoscopic view, that is the advantage of endoscope. And now that I have the cage secure, you can see I'm using the fusion sleeve to protect the nerve root while extracting it. And you can see now how I'm extracting the cage. So this was my first titanium herniation that I got out. So it's a big cage, and I use the same incision and the same approach to place in a bigger cage for the pseudoarthrosis without having to remove all the hardware. So this was a revision surgery with a 2 centimeter skin incision. Okay, so this is the postoperative CT control, and the patient is doing well. So I did a prospective study with almost 40 cases, 38 cases. You can see here the demographics. I placed 51 of those big, large footprint interbody cages. And these are my clinical results. So you can see I have significant differences in VIS back, VIS leg. Right now, I have only 6 months of mean follow-up. So it's still an ongoing study, and we will publish that soon. So, but my take-home message is, well, if you're just going to do it percutaneously using the manual reamers, then you have to be careful with the postoperative dysesthesia, which means the patient get 2-3 days after surgery, they get radiated leg pain because you have an inflammation of the nerve root, of the exiting nerve root. Neuromonitoring will not help you to get that because it's just an inflammation. It always goes away. It's temporary. So you give the patient oral medication, and after 5 to 6 weeks, it's gone. But still, it's very annoying for the patient. So if you use only the manual reamers, I suggest you use smaller cages than the one that I did. But if you want to place a big cage, then you can use endoscopic reaming. Then you can do a much bigger foraminoplasty, and then the dysesthesia rate goes down. Okay, but of course it takes you more time. So with the percutaneous reamers, with the manual reamers, you can do it without endoscope. And I place the cages in 20 minutes, 25 minutes. If I use the endoscope, of course, it goes up to 45 minutes, but you have to know how to use the endoscope. The second part of my talk, and this will be more quickly, is how I use a special protocol to decrease the pain. I was looking for a long time for effective postoperative pain management protocols, and whatever I saw, it was, it took a lot of preparation, it took a lot of time, and nothing really convinced me that it could work in my practice. So what I'm using right now is an ultrasound guided local anesthesia technique. So I place the needle between the multifidus and longissimus muscle on the interfascial plane. So it's on the fascia between those muscles, and I use the ultrasound to get there. So you can see here the anatomy, the spinous process, and you can see the needle coming up from the upper left side. And I'll show, and by placing it, it's like placing, it's having a highway for your local anesthesia, and you get a big area of anesthesia using this. So it's a big local anesthesia. This is the video of the ultrasound. You can see the needle coming from the upper left side. This is the needle moving in, and we're looking for the space between the multifidus and longissimus muscle. And so we're trying to find exactly that joint. You can see here the anatomy again explained. And you will see now how in the moment we inject the local anesthesia, the plane opens up. You can see it now, and the needle is retrieving. And so it just goes along this whole interfascial plane, and you get this big area of anesthesia. So you could use this to do awake spine surgery. So the patient is awake, just with a mild sedation and local anesthesia. And so there's no need for opioid medication with that. I did also a prospective study with this technique. So it was single level percutaneous TLIF cases, single center multiple surgeons. It's a prospective study with a retrospective case control. 42 cases, half of them had a TLIF block, the other half, about 25 cases, had no TLIF block, and we used neuromonitoring. This is the anesthesia protocol, and this is the postoperative analgesia that we used. And you can see that all patients had the same postoperative analgesia, and they had a PCA pump with morphine that they could trigger manually if they needed it, only if they needed it, and we would monitor their need. So this is the demographics of both groups. You can see they're pretty similar. So if we take the TLIF group, the group with the TLIF block, you can see that I have significant differences for all scores compared preoperative with postoperative at hospital discharge. When I have the non-TLIF group, you can see that only the VAS leg score was significantly different. When I compare both groups together, you can see there are no significant differences in the preoperative scores, but at the postoperative scores, I have a significant difference for the TLIF group, which better clinical results at hospital discharge. And you can see it here very clearly. So similar preoperative results for both groups, and at hospital discharge, the TLIF group had much better results. It's of course, as soon as the block effect goes away, so after 1 month, the scores, they settle back again and are very similar. So the same for the VAS leg score. So it's very important that you see, so if I use this block, no patient used the PCA pump. No patient needed to trigger the PCA pump, because they had no pain. They were walking 4 hours after a TLIF surgery, and the median hospital stay was less than a day. While the group that did not receive the TLIF block, despite getting opioid medication, so they got opioid medication, very strong medication, and still had worse results than the TLIF block. So this study I published last year in this journal, World Neurosurgery. And just to give you an idea of how this works, and I'll be done in 2 minutes. So this is 56 years old female, high BMI, chronic low back pain. You can see her, she was in pain. You can see the level 1 spondylolisthesis at L4, L5 here. And so I did a 1-level endoscopic, percutaneous TLIF surgery. You can see here the skin incision for the cage, 2 centimeters, as I showed before. And this is the patient just the evening after the surgery. You can see her walking just 5-6 hours after surgery. And if you look at her face now, you will see her smiling. And she has no opioid medication and had just a TLIF surgery. And she is in no pain. This was a very impressive case, even for me. She didn't even take ibuprofen, no medication at all. And she's doing very well. I have a 2-year follow-up on her now, and she has no pain. This 50-year-old male, he had a previous lumbar surgery on 2 levels. He still was in pain, a truck driver. I did this 2-level TLIF surgery. I used one skin incision for placing 2 cages. And this is him walking after surgery, also 5-6 hours after surgery. You can see him, he walked better than I do, right after surgery. So no pain after a TLIF surgery. Okay, so it's very impressive results. I also combine my surgery with endoscopic decompression surgery for central canal stenosis with crossover over the top. So like this almost 80 years old male, he had neurogenic claudication, low back pain. You can see here the central canal stenosis, very, very tight. Here also, I placed 3 cages using one single skin incision. Okay, so 3 levels TLIF. You can see here before the contralateral decompression, the endoscopic view, you can see how I go here over the top to the other side. And this is the bilateral decompression. All of you guys know how to do it, so I don't have to explain. Preoperative CT scan, postoperatively how I decompressed. This is the postoperative X-ray. You can see a nicely 3-level TLIF surgery. And this is this gentleman who could barely walk before surgery, at least not without the help of a cane. And he's walking here after surgery. Okay, so very last case, 76 years old, female, very strong back pain. You can see here multiple level spondylolisthesis, instability, degenerative disc disease. Okay, so in this case, I used the TLIF combined with anterior to psoas surgery. This is how it looks like. I go up to 4, 3, 2, 1, yeah. And so this is the lateral incision, this is the TLIF incision, and this is the lady just walking, 76 years old. This is her walking the next morning, okay? So I think you get the idea. So just to conclude, a strategy which involves a very, very little invasive surgery with endoscopic or percutaneous TLIF, using a large footprint interbody cage gives you the best of both worlds. You have a large cage, you have very little invasiveness, and using a TLIF block takes the pain away. So this allows opioid-free analgesia, awake spine fusion surgery, very quickly mobilization of the patient, early recovery, and hospital discharge in less than 24 hours. So you can use it in very morbid patients, very sick patients, very, very big patients, and still you will get good results. And this is actually it. So thank you very much for your attention. And thank you for having me again in this very, very important and nice meeting. So thank you very much.
Thank you very much for your kind lecture, and it was very informative to us. And we thank you once again for participating in our didactic course, Dr. Morgenstern.
Thank you very much. Thank you.
Thank you very much.